And so I wanted to start off with our mission, vision, and values. As you are well aware in organizations, this is the guiding principle of any organization. And our mission as a nonprofit, we exist to provide healthcare services to the communities that we serve. And every dollar we earn is reinvested to provide quality healthcare through new and expanded patient care services, access to care, new physician services, new technology, and attracting and retaining engaged professionals who share in our vision. Okay? Vision. Astria Health builds sustainable healthcare organizations that deliver comprehensive quality care to improve health in the communities we serve. And our values, which are our guiding principles: integrity, honesty, stewardship, and respect. And to give a little introduction to the Astria Health executive team, myself, Carrie Rowan is our Chief Financial Officer, Dawn Opolka is our Chief Marketing and Communications Officer, Janine Sartee is our General Counsel, Mark Lauderin is our Chief Information Officer, Brian Gibbons is our Chief Executive Officer for Astria Sunnyside Hospital, Eric Jensen is our Chief Executive Officer of Astria Toppenish Hospital, and Rich Robinson is our Chief Executive Officer for Astria Regional Medical Center. Just to give a snapshot of the system, we have 3 hospitals in the system that I mentioned before. From a snapshot perspective, as a whole, we have 316 beds, roughly 7,000 to 8,000 admissions with 80,000 ER admissions, over 7,000 surgeries. We have 609 physicians on staff for combined net revenue at the end of 2016. Talking about Astria Health from a collaboration perspective, Astria offers an infusion of resources and access to capital. We're able to provide market position leverage, create ability to improve operational efficiencies, support community partnerships aimed at identified health needs and population health. We reinvest in the region and the economy, and we build a track record of successful turnarounds. We have experts in smaller rural hospitals, critical access hospitals, as well as large health systems, hospitals and health systems. And we continue to successfully build robust service programs and attract talent. With that, I'd like to turn it over to Dawn, our Chief Marketing and Communications Executive, to talk about why we rebranded. Dawn?
Thank you, and thank you all for having us here this evening. We appreciate it. As you may know, you may have seen in the news, Astria Health, which was formerly Regional Health, has made the decision to rebrand for a lot of reasons. And these are some of them. So one of them is that as an organization, we were many different types of brands, and we were not coming together yet as a united brand. So a brand is really about the promise that we want to keep to the communities that we serve. And for us, that really means about being the type of organization that is very nimble, very entrepreneurial, that looks at healthcare from a different perspective, from a different point of view, to meet the needs of our communities, because each community really does differ in what the population is like and what the people need in those communities and the strengths of the communities. Secondly, we brand because we want to be different. You know, we want to be different from other healthcare systems. We want to be different from other organizations. We want to be the type of organization that can move quickly to actually make solutions that are needed in our communities. The other thing is that with us being many touch points with the community, what we found that the community doesn't know that they're us. So we needed a unifying brand, a name and a logo that would unify us as an organization so people knew who we were. And then we now serve a very broad geographic footprint. So we are in many different markets, and having a name that was just one, like one hospital, did not communicate that we were actually serving people across a broad geographic market, nor did it communicate that we were providing care on a continuum of care. In other words, all the way from primary care to ambulatory surgery care to, outpatient care to community hospitals, tertiary hospitals, home care, and then actually hospice. So we wanted people to know that they could connect with us no matter what their generation or their age, and that we could do this throughout the lifetime of our communities. Also, as an employer, we needed to stand for something as employees that was about providing quality care, and we needed to stand for that as an employer. So we want to be the type of employer that people want to engage us, so they understand our mission and they actually want to work with us on behalf of our patients. A brand guides your interactions with one another. It breaks down silos, so you're working together to find solutions. You're not working in these silos. And then it really is about us providing our value. Very often people didn't know who we were, so it was hard for us to share what our value proposition was. So this is where we were with our different brands, and you can see why there was a need to brand, to create our own unified brand. We were marketing under 4 different major brands. We used Regional Health initially because of the fact that as we went through the acquisition, the CM process for the hospital in Yakima, everyone in the hospital in Yakima knew that hospital as regional, and we needed to support that hospital until we could complete that acquisition. So we did a lot of marketing under that name. But we were also marketing in 3 major hospitals. There was Sunnyside had a brand, Toppenish had a brand, and Yakima Regional. So that's a lot of different organizations to sort of get to know. It made it very difficult to communicate about us. In addition to that, we were marketing, we had 40-some clinics, and urgent care centers, and ambulatory surgery centers. Every single one of them had a different name. And, we, as an organization, it's very, very hard resource-wise even to communicate for each of those names. So people didn't even know they were a part of us. Even internally, our doctors told us we didn't know that that was a part of, Astria Health. So that it was hard even internally to communicate that type of information. So this is one of the things we looked at is the brand and how we compared with other major brands from the perspective of the look and feel of the brand. So you can see the Astria Health, that is our new system brand name. And you can see we took a lot of care in making sure that from a visual perspective, we could really stand out among competitors when we were in the marketplace with them. That's really important so that people see you immediately. These are the brand, and then we took our system brand and actually applied that. It's called a borrow to build strategy. So we're building the equity of the Astria name, and there is equity in our existing hospitals. We don't want to lose that image and that reputation of those hospitals. So what we did is we took, for example, Sunnyside Community Hospital, we put Astria, the brand logo and the name next to it. So it's Astria Sunnyside Hospital now. Toppenish is Astria Toppenish Hospital. The Yakima Regional Medical and Cardiac Center, we heard a lot of feedback from the community. It was way too long. They didn't really know what it did. So we brought Astria up to Astria Regional. We kept that regional name, medical center. It made a lot of logical sense to do that. And because the Regional Medical Center has got a huge cardiac program, we actually branded that as Astria Heart Institute to really protect that particular piece of their business, and so people were aware. We, as I told you before, had maybe 30, 40 different clinics. We now have put them all under one umbrella name. So all of our clinics are called Astria Health Centers, and then we identify them by their street, their city, maybe their specialty, so that when folks are driving around the region and they see that sign, they say, oh, I can go there. It's also important from a mobile perspective. For example, internet perspective, that you can actually find those clinics that are part of us. And then we had we had 4 what I would call urgent care clinics that people didn't really know they could go there for urgent care. So they would drive right by them because it just said something like Vintage Valley or something. They didn't understand the generic name of urgent care, so we applied those to those urgent care centers. So we just completed our launch. We did a lot of work on this. This is sort of how we rolled out the launch of our brand. We started with research and planning, and that's been actually going on even before I came there. Immediately in February, we started to plan for the acquisition of those 2 hospitals regarding the go-to-market strategy, knowing that we wanted to get that out there as soon as we could after the acquisition was completed. We met with our local boards of directors and talked with them, made sure they understood, and make sure that they provided us with input. So we spend a lot of time listening to them. We just completed leadership update meetings with all of our directors, VPs, all of our leadership teams so that they understood it, could communicate it to their communities, then had meetings with their physicians and doctors. And then the 17th of October, after we had communicated internally, we did a huge launch externally. So that included everything from a very robust, integrated marketing communication strategy, and I'll show you some of that in a minute, that is really planned for the next 12 months into the future. It's intended to be very customized, and it's intended to be sustaining so that we can continue to really build new programs and communicate those to the community. It's advertising, including all of our signage, promotional items, our websites. We have 4 websites. We're bringing them all together under one. Leader toolbox, so we had all the tools that our leaders would need, from letterhead to business cards to press release templates, all of that automatically so that they could just go get it and start to tell our story. Scripting for how our folks answer the phone, because the name is hard to pronounce, so we did quite a bit of broadcast marketing so people could hear that name. The other thing that I love is the work that we've done internally with even such small details as having our email addresses being dawn.apolka@astria.health. .health is a new domain. It's always been .edu or .org, but it's just the chance to take this came up right when we became a system. So everyone in our system, all 1,400 employees, carry that unified domain. This is how we have introduced the brand. So the way we've done this, first of all, is to, and this is all together at varying times throughout the month. We started with explaining regional health is now Astria Health, then explaining that all these different hospitals, for example, are now Astria Health and then their new names. And then talking about the value proposition of what we are as an organization as a whole. So that's how our print advertising looks. It's in newspapers, it's in magazines, it's all over the place, communicated. In addition to that, we customize the way we are communicating this in communities. So for example, on the billboards, there's the overall Astria Health. Regional Health is becoming Astria Health. But when you live in Toppenish, those boards are about Toppenish Community Hospital becoming Astria Toppenish Hospital. In Sunnyside, it's a little different board. And in Yakima, it's a different board. So that allows us to communicate that change, but to really vary it by community. And for example, we try to put graphics in that are for that specific market. So it depends on the market we're in. It's very easy to switch out your graphic so that you get the local feel. That's really what we're trying to do with the campaign. We have done a very robust digital and social campaign as well. We have a lot of younger people that this is how they get their information. So this just gives you a sense of the type of ads that we have. And we also have these on our website. So everything people is touching, we use every opportunity to communicate who we are and to share that message with them. So we have, for example, a campaign that we took all of our Facebook social and put it all under Astria, so that if the Facebook people are looking there and that all of our hospitals share in that, for example. We have Instagram, Twitter, we have LinkedIn and YouTube. So social and the new media is really where you need to be, and we've put a lot of work into making sure that we're in that, for that demographic. As far as the type of media that we've used, we really try to own the local media. So for example, we are on obviously TV, and we will often be in the local news before and after, because that's where people most often, our research shows us they're looking, but also on Univision, because that's our demographic in the Valley. We really need to be more diverse in who we're communicating with and how. The same with the newspapers. You'll see we're in El Sol. We're also in, obviously, the Yakima Herald Republic. We're on Pandora. Pandora, we have found, has been a really wonderful way to target and to really get your message on. So we have a radio on Pandora. So if you love whatever, you live in a certain zip code, you're going to actually hear our ads. Also in magazines, we're on News Talk. We do a lot of, this morning, for example, we had several of our doctors on talking at one of our radio stations. So there's a lot of public relations involved with this as well. We have our identity systems. We have a brand identity system, and we have incorporated into that identity system a lot of flexibility. So that, for example, these are just ideas of the color palette, for example. So although our logo is the colors that you saw, we have a color palette that allows us to really be diverse in how we might want to communicate for a hospital. So for example, this is just an example. It's not necessarily that we would do this, but if we want to talk about Astria Hospital's birthing center, we can use a certain color, for example. Or if we're doing something about Chew the Flu, for example, we could do it under an Astria Health Center, where you want your doctors to be taking care of patients coming in. Our Heart Institute, for example, could be specifically red, depending on what we want. So this gives you a sense of the type of flexibility that we've tried to really build into the identity system. We also did our signage. So this is what the signage, and we have a lot of geographic assets when it comes to our places that we're at. But they all looked different, and they were all, people didn't have the same name. So now all of our campuses have common signage so people can find us easily. I mean, it's really about finding healthcare, the healthcare you need in an easy way. So that is how that looks. And we wanted to see how our brand would look on promotional items, for example. So we have stacked and we have horizontal versions because, as many of you know, what your logo is going to look like on a pen is going to look very different than the way it looks like on a t-shirt. And so this gives you a sense of how that looks. And this is how our website will look from the beginning. We're bringing those all together. And then, my point in sharing these slides is, powerful brands really start in a very innovative types of ways. So, for example, when you look at the Target brand, the evolution of that brand, we started with a little a grocery store in Minnesota, grew into this very sophisticated high retail market, whereas now they have really great designers who are coming in and actually designing their products sold to people like me that can afford it. So, and even an organization like Mayo Clinic, where it started with one doc, right? It has to start somewhere, because then you have that commitment to really build that culture. And you can see these are examples of the types of brand that started really small and became very, very successful. And the thing about them is they often will be the disruptive innovators that will leave another industry in a different place, right? So when you think of the iPhone, when you think of all of the industries that has impacted because of the innovation, that's the kind of way that we want to think about healthcare. We want to think about it differently. We think it works because it works in your community. These are a few others. I won't go into all of them. But you can see, Lego started with just a toy maker. It starts with one, right? It starts with one person making the difference. Guess what this brand is?
Starbucks.
Not this one, but it's pretty close. This brand, guys, started one you know very well, which is the Harvard brand, right? So you would never know it, right? But someone drew that out, and that's sort of where they started. Guess what this one is? You know this one? So it's Newton, right? Sitting under an apple tree. And he's got something going on with Wordsworth in there. This is the beginning of Apple, which we all know started in a garage, right, in a house. And it's all about how organizations for innovators start. And so that's really the point of this. I just wanted to share a little bit how I've seen brands grow. I wanted to give you a very quick update on what happened with Affiliation so that you are aware of that. I'm not sure if you knew from the last time what happened during the CN process and so on, so we thought it might be helpful to you to know. So, on July the 11th, We went through 2 public hearings with the Department of Health to approve or not approve the CN that we were applying for. We had tremendous support from the communities, and that's what you're seeing here. The rooms were totally full, both in Toppenish and in Yakima. We had over 240 letters of support from everyone from all of the legislators in our area to Mr. Representative Newhouse, to doctors groups there, to the medical schools there, to community leaders, transportation leaders, on, farm workers union, physician groups. So a lot of support, which proved to be successful to us. So in September 1st, we had the approval from the Department of Health, and on September 1st is when we actually went through the acquisition and was able to purchase those hospitals. So very fast moving, you can see how fast this organization works. And then on October 17th, a month and a half later, we are ready to launch the brand because we had been planning for that right from February. So it gives you a sense of how quickly we're able to work because of the fact that we're very nimble and we think differently about how quickly we can get things done. And if we don't, John will tell us, we're going to get that done. So we can do it. So that is what I wanted to share. And at this time, Jody's going to talk a little bit about Sunnyside, because she's been involved with it from the beginning, about sort of the turnaround of the Sunnyside Hospital.
So my name is Jody Corona, and I see a lot of familiar faces around the room. I am a consulting firm. I'm the principal of that firm, and we do strategic planning and healthcare consulting for hospitals throughout the Pacific Northwest. Been in business for about 35 years now. I'm looking at a lot of people that I knew for a very long time in the room. I've had the privilege, my area of passion is really smaller hospitals, specifically critical access hospitals. We've had the privilege of working with your hospital before. We actually were retained by Sarah and Steve to do some of the data, the market data that you saw back in, I think, March or April timeframe, looking at your market and the opportunities for that market. We've also had the opportunity, I've worked with Astria Sunnyside when it was Sunnyside Hospital, under former leadership, not the current leadership team, and we watched that hospital struggle for a number of years, sat through many board meetings where there were discussions about what services need to be cut, what staff need to be reduced, and there was a new leadership team brought in. And what I want to do is go through a couple of slides. In my 30-some-odd years, the change that has happened in that hospital is unprecedented. I've never seen the kind of growth, new service development, and new access points. So that community now has a large number of ways to access the hospital, and I want to just give you a couple of highlights that I've seen. This is, again, this data is all readily available. I'm just kind of compiling it and giving it back to you. But you can see what's happened to Sunnyside. Astria Sunnyside, it went from a negative position to a position where it's really been able to generate significant net surplus over the last, since about the 2012 time frame. Pretty significant dollars. We keep a database because we do so much work with critical access hospitals. I do not believe that there is another critical access hospital in our state that's experiencing this kind of sustained performance. What that has turned into is a pretty significant contribution, capital reinvestment into the community. It's supported the hospital, but more importantly, it's supported new access points, new services, new providers, and has really contributed greatly to that community. So you can look at the dollar amounts there, very significant. I hope everybody realizes how phenomenal some of these statistics are. So over the course of 2012 to 2017, that hospital has added 76 new providers, 76. They have added about 44 new services, and they've had 5 acquisitions. So acquisitions of ambulatory surgery centers, speech and hearing centers. I'll go through this with you in a little bit more detail. Here's a summary of the physician recruitment additions. What I want you to see is it's not just primary care. So again, the mix of services makes Astria Sunnyside stand out. I am not familiar. There are 39 critical access hospitals in Washington State. I am not familiar with any other critical access hospital that has this scope of services, again, to benefit the community that it's serving. This mix of services is pretty spectacular. So orthopedic surgeons, nephrology, mid-levels, large number of births in that community, vascular radiology, general surgery, neurosurgery. Won't read the whole list to you. Cardiology, urology, and a psychiatrist. You're going to see that there's been a real commitment in that by Astria to build psychiatric services for that community, and you'll see them in a couple of different ways. This is a list of services. Again, I won't go through the service additions line by line, but I do want you to see the commitment that's been made, again, the new access points and the kinds of services that have been added in the past 5-year time frame. So hospitalists, a school-based health center, just one example of where the hospital says, how do we get access points that are going to make getting care easier and get patients into care more timely? And that community is school-based health center. So there's actually a physical school-based health center in one of the local schools in the district. But we are now rolling that out with telemedicine to every single school in that district, working closely with the school nurses to make that happen. Urgent care, interventional radiology, 3D mammography, cardiology clinic, a cath lab. So that hospital operates a cath lab, busy cath lab. They've got imaging centers and oncology centers, stereotactic breast biopsy. The list goes on and on. On the right-hand side, you can see that there's been a couple of acquisitions, an ambulatory surgery acquisition, but we've also have state certificate of need approval to develop an inpatient psychiatric unit. There is already an outpatient psychiatric clinic operating. Home health has been added. Again, there's really this consistent theme of trying to understand, assess what the community's needs are, and then develop programs to be responsive to that community. What I want to do now is just switch ever so slightly and talk about your community and the opportunities that Astria sees in your communities. So they had access through your RFP process to the work that I did for you folks back in the spring of 2017, the market assessment. And these are some of the notes that they have taken away from that opportunity. This slide is just a verbatim slide of my first slide in your presentation, talking about what it was that we were commissioned to do, what health facilities planning and development was commissioned to do for your district, and what we looked at. So it's going through the kinds of data that we looked at. Astria Health concurs with takeaways. So they have devoured that study, questioned me in a couple of areas, and come back and said, that makes a lot of sense. What we see in your market, and I'm sure you folks live here, work here, so you know these to be facts, but both your primary service area and the district are growing rapidly, very fast. And aging. So even though you are very young today, what we expect to see is a significant growth in the 65+ population. If any of you have trouble sleeping and you choose to look at the National Ambulatory Care Survey data produced by the Centers for Disease Control, what you will see is that folks age 65+ use healthcare services at 3 to 5 times the rate of the under 65. So inpatient, outpatient, across the board, much more utilization of services. So as your community grows with young families, it's also aging, and that's going to produce some significant increases in utilization. What we see in the data is that your inpatient market share is exceptionally low today, about 1 to 2%. I'm aware of one other hospital in the state that has a market share in that range. We typically want to see, what I tell is the critical access hospitals, if they're in the 40 to 50% market share range, that is pretty optimal at that point in time. And then you have an exceptionally strong commercial inpatient payer market. Medicaid and self-pay are, keep using the word exceptional in my presentation, but they're exceptionally low. This is a very attractive market, and we think that there are a lot of opportunities here. Again, looking at the population, what we know is that we've had strong growth. Since 2010 alone, the population has grown by about 15%. And I'm sure that doesn't surprise any of you with the housing construction that's happening today. The data is telling us, Claritas and both Office of Financial Management data is telling us that we expect another 20% growth in population in the next 8 to 9 years. So pretty phenomenal growth rates. Population is young. Less than 10% of your population today is over the age of 65. For comparison, statewide that number is about 15%. So you're considerably younger than the rest of the state. But the 65 plus is growing about 10 times faster than the younger population. So people are aging in place. They come here, they want to stay here, and they're aging in place. If we took a look at everybody that was hospitalized as an inpatient in a hospital at midnight, that lives in your district, somewhere in a Washington hospital, what we see is today the census is about 33. So on any given day, there are about 33 residents of your district hospitalized in some hospital as an inpatient. That could be here, that could be somewhere in Seattle, that could be somewhere in Spokane. But about 33 patients. Even if we assume use rates are flat, so the number of patients per 1,000 population that get admitted, your rate is low today. We assume that low rate will continue simply because of population growth and aging. We expect another 25% higher rate of hospitalization by 2026. The other statistic that I think is interesting is if we make the assumption that 100% of all district residents stayed locally for their care, you would need 33 primary care providers to meet the demands of the population by 2026. Now that's not necessarily a good assumption, to assume 100% of everybody's going to stay locally, but it gives you the sense of the market. The market is large, it's growing, and again, we see significant opportunities. So the market shifted rapidly. Again, I'm not telling you folks anything that you don't know. When we're looking at inpatient data, what we can see is that the current market leader in the community, the dominant provider, increased their market share from 12% back in 2010 to 53% last year. Your market share decreased back in that same time frame. You were at about a 7% inpatient market share. And typically what we see when a provider opens a new hospital, we can track a bump. We see market share actually increasing. We didn't see that in your case. We saw a flat and then a slight decline again. So a little less than 2% market share today. And because that provider is so dominant in the market, everybody else has lost that market share as well. You're not alone in that market share loss. Most common reasons for hospitalization, residents that live in your community, those 33 people that are hospitalized on any given day, the 3 most common reasons for them to be in a hospital is for a general medicine need, for an OB to have delivered a baby, or for an orthopedic case. A lot of those kinds of services are very appropriate to be provided in a critical access hospital setting. And then on the outpatient side, because so much, unfortunately the data that we have is inpatient-centric, we are very well aware that the trend is on the outpatient side. And so we look at Truven data when we're trying to understand the size of the outpatient market and the opportunities in the outpatient market. And Truven is claims data. It's a proprietary, it's a for-profit national company. They purchase Medicare claims data, Medicaid claims data, commercial payers, and then they have a secret algorithm that they use to make adjustments for specific markets. And what you see, again, this was data that we presented to you folks back in April, but by 2026, so 8 years from now, we expect that residents of your district will generate about 160,000 visits to providers. That's both primary care and specialty. They'll generate about 7,500 emergency room visits, about 6,000 outpatient surgeries, and then a large volume of imaging as well. So I just picked the higher volumes out of the report that we had that was provided 2 months ago. That's kind of it for the data summary. Thank you. John, back to you.
Well, I appreciate that. Moving on from here, I wanted to talk a little bit about as pertains to the RFP response. From Astria Health's position and vision for Snoqualmie Valley Hospital, we realize the promise of the hospital's state-of-the-art physical plant and its talented and highly qualified leadership team and staff by being responsive to the market, providing patient and provider choice. As Jody mentioned, and as we've seen in our other markets, our strategies include expanding services with recruitment and retention, a robust panel of primary care and specialty physicians, investing in facility modifications and staff development necessary to support growth and leveraging the hospital status as a critical access hospital while simultaneously positioning it for success in a transformed environment. Our ability to execute on this, as requested, is confirmed by the performance of our other hospitals. Astria's Sunnyside Hospital case study that was mentioned earlier, success positioning, leveraging critical access hospitals for success. The quick opportunity to close the transactions quickly. After the CN approval, we actually received the approval on August 31st to close the transaction on September 1st. So within 24 hours of approval of the certificate of need, we had closed the transaction. And then also in that whole process, for the certificate of need process, the Department of Health issued its decision approving the acquisitions, including that we had met all the criteria necessary. When I look at the mission, vision, and values of Astria Health and Snoqualmie, they align. Snoqualmie's mission to promote and improve the health and well-being of the community by providing quality care in a collaborative environment. The mission of Astria as a nonprofit exists to provide healthcare services to the communities that we serve. Every dollar is reinvested, providing quality healthcare through new and expanded patient care services, access to care, new physicians, new technology, and attracting and retaining engaged professionals who share our vision. The vision for Snoqualmie to the community will be the healthiest in the nation. Astria Health builds sustainable healthcare organizations that deliver quality care to improve health in the communities that we serve. And then core values for Snoqualmie: trust, integrity, collaboration, quality, innovation. Astria Health: integrity, honesty, stewardship, and respect. They align very nicely. And as we talked earlier about certificate of need in that process, just to share some of the aspects of collaboration. From a collaboration perspective, a lot of our collaborators in the markets that we are in provided letters of support. For example, Yakima Valley Farm Worker Clinic, 10-year partnership. They depend heavily on a strong and viable hospital, and Sunnyside has been that institution and continues to be that institution to provide excellent services to the community. Betty Thompson, Associate Program Head of Cancer Prevention at Fred Hutch. We've had a long relationship with Fred Hutch in the Valley for promoting health and healthcare for the underserved. We provide local resources and access to the residents of the area instead of forcing them to seek care elsewhere. Mike Maples, CEO of Community Health for Central Washington, which is a federally qualified health center, and they're a nonprofit entity there with the longest running graduate medical education provider in Central Washington. They facilitate the family practice residency program through the University of Washington Medical School, and they rotate through the hospitals there at Astria Regional Medical Center. And we continue to have a strong relationship with them and depend on each other for support and collaboration for that program as well. This is from Gary Staples, who was a prior board member of the Yakima Hearing and Speech, which Yakima Hearing and Speech was an entity that was the largest hearing and speech center in the Pacific Northwest, with over 20,000 visits a year. That institution was getting ready to close. They had reached out to numerous providers in the community to try and facilitate a relationship, and we were able to come in and work with the board, and his comments there, visionary thinking and sound economic practices let us maintain the clinic with no interruption of services to the patients and retention of the qualified employees. We were able to bring them in underneath the hospital to keep that service in the community. Madeline Carson, CEO, People for People. Of course, as you know, a statewide organization does 211 and a lot of transportation in the state. Astria Health System preserves critical access points for residents of the county, and it's a system that understands the needs of the community. So our goal is to position Snoqualmie as a thriving healthcare provider. We have a reputation for being entrepreneurial, nimble, acting quickly on behalf of patients and communities. We continue to have rapid success in the Valley and strong competition. We are the largest healthcare system based in Eastern Washington as well. And we continue to compete successfully. We build successful partnerships to build healthy communities through partnerships with private practitioners, community health centers, schools and civic groups, family practice residency programs. We actually have two that rotate through our facilities, economic development agencies, transportation providers, and care plans as well. Here is a representation of some of our partners. Pacific Northwest University from a medical school perspective, UW, associated with Central Washington and the family practice program, and the community health centers. Community Health of Central Washington, Fred Hutch, Yakima Farm Workers Clinic, SCIU, and WSNA both wrote letters of support for our acquisition of Yakima and Hopkins hospitals. We continue to have hospice, palliative care, and senior living and as partners as well. Sunnyside United, focusing on youth prevention, Choose Yakima Valley from economic development to school districts. Heritage University, we have relationships there, Yakima Valley Community College, Yakima Valley College, for nursing programs, West of Casa, People for People, the museum, school districts in Topinich, Greater Yakima Chamber of Commerce. So we continue to build relationships and have strong relationships with our community. And we're known by providers and policymakers as an organization that looks out of the box to find better ways to serve local communities. We focus on quality, accessible, patient-centered, well-focused care to maximize status. We continue to use seamless care transitions, such as telehealth and virtual strategies. And we focus on using a robust community health needs assessment to be able to drive the strategic plan. So we look at what's being utilized, what the community needs, where is that gap, and how can we fill that gap. Here's a comment from the legislators in our district. Vetted that time regional health, Astria Health, highly confident in the ability to improve access, retain choice, meet community need. Their operational and quality expertise, coupled with their financial resources, will assure a smooth transition of these hospitals back to the community. That was from the legislators' letter of support for the certificate of need process. And then from a transformation perspective for Snoqualmie, we will listen carefully on feedback to transform the hospital, establish board composition, and develop strategic goals. Elected commissioners will still have their fiduciary responsibility for collection and distribution of taxes, provide support for the bonds in the hospital itself. We hope to build upon a strong base that you've already created here, leverage shared similar mission, vision, and values and strategic goals to focus on patient and community needs, retain employees and providers. The district board will still have their legally required functions. We plan to maintain current services but grow on those areas. And both the hospital's charity and community benefits program will continue. Continue from the standing positioning and development of the hospitals. We focus on that with our local hospitals, developing key partnerships like we talked about and out-of-the-box thinking. And that community focus to help identify and prioritize local community health needs. With a strong emphasis on maintaining healthcare close to home rather than having the hospital function as a referral base for other institutions. Again, here's some of the representation, some of the quality indicators from Commission, CARF accreditation for rehab, 10 years healthcare most wired by Health and Human Hospitals and Health Network, Certified Chest Pain Center, Commission on Cancer Programs, American Heart Association certification as well. Now, from Astria Health perspective, just to give a little background and touch points on some of these things, Astria Health's roots date back to 1947. Originally started the roots of the organization, Astria Sunnyside Hospital. And then in 2012 to 16, we converted it Sunnyside Community Hospital, transformed it as Jody talked about in her case study. And in 2016, we formed, at that time, Regional Health. And then in July, the Department of Health approved the purchase. September 1st, we closed on July 11th. We had the hearings. August 31st, the approvals, and we had the closing on September 1, and we rebranded on October 17th. Our strategic priorities, again, this is just a reiteration of our mission. So we provide healthcare services to the communities we serve, and investing into the items that we have already spoken about. Fulfilling our mission, focusing on cardiology, we know your heart. These are new cardiologists we recruited to the market, focusing on access points, a new clinic here, a transition plan here. And then with our market, bilingual advertising, a large portion of our population from that perspective as well. This is our psychiatrist here doing an interview as well, and in our student health center. Looking at just collateral from a marketing perspective and having all of our physicians listed there, and again, showing that process and fulfilling our mission. Organizational charts, so Astria Health is at the top, and then below that we have the 3 hospitals, and then each of the hospitals have separate departments or subs as well. And from a financial position, more financially positioned to serve the district and transform the hospital. We're uniquely qualified with proven expertise when it comes to turnarounds and critical access hospitals. Astria Health and our subsidiaries have no outstanding long-term bond debt. We have access to capital from multiple sources. We have at this time $1.13 billion in gross revenues and $50 million in debt. And we have strong ratios compared to other national and state systems as now and as projected. Clinical integration and physician relationships. This next slide here. Continually seek best practice strategies for improved clinical outcomes with our partners and medical staff. We operate comprehensive care coordination program to address chronic care management needs of our lower valley hospitals and other hospitals as well. We focus on chronic care management, and we have a consortium goals to reduce the rate of advanced chronic disease, the cost of inpatient utilization associated with managing the chronic disease, and focusing on population health. We focus on coordinating patient care and sharing information among all the parties. We have an evidence and value-based system of care focusing on improving outcomes. We're also actively engaged in bidirectional behavioral health integration. And what that is actually putting primary care into behavioral health offices and putting behavioral health providers into primary care offices. We're also an owner and participating member of Magnolia Evergreen Accountable Care Organization, which is a Medicare shared savings ACO. I'm the president and CEO of Astria, but also the treasurer and ACO of the ACO governing body. We also focus on analytics, patient satisfaction analysis, and evidence-based medicine in that program through enhancing through the membership. And in our first year of participation, the results we received were outstanding. We saved Medicare $11 million, we reduced inpatient utilization as an ACO 17.7%, which is the most the National Rural ACO had ever experienced. So from a value-based purchasing perspective, we are a healthcare innovator committed to value-based care and utilizing emerging payment and care delivery models. We also are partnered with the accountable communities of health in our regions and to ensure the strategies advance the health of our communities and healthcare transformation as we work with the state's Medicaid transformation program for healthcare Washington. The Astria Sunnyside Hospital CEO Brian Gibbons is actually on the Greater Columbia Accountable Communities of Health board, and he is the treasurer of the ACH as well. So we've been engaged in this program from the beginning and have continued to focus in that process throughout the state. From a technology perspective, Astria Sunnyside, as I mentioned earlier, has been awarded with the Hospital and Health Network Most Wired recognition for 10 years in a row now. And we are actively implementing a system-wide integrated information system upgrade. We were involved, our providers, in interviewing and selecting different electronic health records systems. And the medical staff unanimously approved the CERN selection. And the point here as well is Snoqualmie we all have IntelliChart. It is a Cerner partner and connects to the Cerner platform via a single bidirectional interface, which is very helpful for data exchange. Provider participation involvement. We are extremely respectful and continue to communicate with our team of physicians and leaders. We expect all of our folks to do so and deliver high reliability medical solutions. And physician recruitment as a process, as a component of that, and retention is its core strength. We use a multifaceted approach to physician recruitment and retention because not all programs are fit for the situation. And over the past 5 years, as was mentioned earlier, we recruited 76 providers to Sunnyside locations specifically. And then since the announcement of the acquisitions of those Yakima top nurse hospitals, we were able to recruit 16 additional providers as well. From administrative functions, the Astria Health corporate infrastructure supports the member hospitals, CEOs, and leadership teams. We have resources that are at the system office level for quality, including mock surveys and those sort of things for hospitals, public affairs, marketing, communications, revenue cycle, information systems, finance, legal, compliance, human resources, group purchasing access, population health care negotiations, governmental affairs, and lean process improvement. And here is another graphic representing some of those areas in strategy, operations, clinical quality, and governance and leadership. And we have access to all of these services for our member hospitals. The decision-making process in our system, we rely significantly on our local board members, and practicing physicians, and key strategic decisions. For example, service expansion, physician recruitment, growth initiatives, marketing, and communication input. Our operating and capital budgets are developed first by the local hospital leadership, and then submitted up through that process for approval at the Astria Health leadership board level. In addition, we focus on routine capital. You have to reinvest back into your facilities. We have a routine capital allocation process back to the hospitals, and then other specific high-priority capital projects, either urgent need or paid need, or take advantage of new service or time-sensitive market opportunities. We focus on that as needed as well. And just from an illustrative perspective, since 2012, when Jody talked about that, we averaged 14% annual operating income over that 5-year period. growth in net operating income, generated that surplus of $34 million, and reinvested back into capital improvements, service development, physician recruitment, and those sort of things. And introduced a lot of services not typically seen in a critical access hospital, but was needed by our community. And then also, since that recent acquisition in September, we're seeing positive results at Astria Regional Medical Center and Astria Health Hospital as well. You can see here some early results. Acute census at Astria Regional up 13%, rehab census up 68%, med up 11, MRI 6. Toppner's Hospital early results. Oops, sorry. Catch up there. You're not connected. So you can see those are just some early indicators that we've seen since the acquisition. Toppner's Hospital early results. Average daily census up 15%, births 42%, inpatient surgeries 53%, and outpatient surgeries 100%. And focusing a little bit on the transaction options, as we indicated in our RFP, we're looking at two options. One option is a long-term lease, 25 to 30 year, where we have the district stay intact, and the district will retain its taxing authority in that process. Astria Health would then lease from the district real property and tangible assets and the healthcare delivery process. Astria Health would be the Snoqualmie Valley Hospital operating entity, and we would bear the risk of the operations. And then we would have the option to acquire the hospital in the future. Second option is a merger option. This is where the district still stays intact. The district still retains its taxing authority. However, a new 501c3 would be established by the district, and all real property and intangible assets would be allocated to the new 501c3. The new 501c3 would govern the operation of the hospital. The new board composed of local community residents. Then Astria Health would become the sole member of the new 501c3, therefore bearing the risk of the operations. And Astria Health would have reserve powers that the hospital separated from the hospital. Transaction benefits. Astria Health as its operating entity would commit to supporting Snoqualmie Valley Hospital both financially and operationally. We estimate $10 million in investments for the first 24 months. We would leverage Snoqualmie Valley Hospital investments already made to ambulatory and physician growth initiatives and continue to make investments supporting physician alignment. Capital needs would be determined from regular assessment and business planning, especially for growth of specialty services. Areas where significant shared service efficiencies and benefits might be seen in an affiliation would be for example, legal services, for contract labor negotiations, marketing, communication, support growth, access to higher levels of GPO tier as part of the system. As you know, you're part of a GPO, but as your volume increases, the tier that you go into improves and your savings is greater. And then physician sourcing and recruiting through in-house physician recruiters combined with standard physician contract terms and templates helps reduce that onboarding process. Eventual migration to a common IT system at pre-negotiated rates that we have with Cerner for adding additional hospitals, as well as finance and revenue cycle repair contracting. So all of those support areas would be available. And last, just wanted to again go back to our mission, vision, and values, and indicate that there's strong alignment for the future, and all of these mission, vision, and values as presented here. I thank you all very much this evening for taking the time to listen to the presentation.
Thank you very much.
So with that, I'm sure that there's questions of Mr. Gallagher and his staff. So we can either take turns, or I can just start at one end and go back and forth until we run out of questions. I'll put you on the spot, CEO Parker, and let you begin with a question. And go ahead and direct that to Mr. Gallagher. And Mr. Gallagher, I'm sure you'll advise us if there's other staff can answer questions. Thank you.
John, I know you just started on the integration of 3 hospitals, but curious about with the acquisition of 2 for-profit hospitals coming together with a non-profit hospital. Can you talk a little bit about how Astria is coming together to bridge and merge those hospitals?
Certainly, thank you, Tom. Just to share with you the history of those hospitals, they have a long history of nonprofit status in our communities at both Toppenish and Yakima. And so being able to bring them back to the community and have a community focus as a nonprofit local system has been very, very positive. The feedback that we received in going through that certificate of need process, letters of support, community outreach, and all the staff that came to support as well. Dawn mentioned and showed the pictures earlier about all of the folks in the hearing room. Actually, in the Yakima certificate of need public hearing process, the room was so small that they turned away hundreds of people that were outside that couldn't access to come in and support the process. So integrating the culture has been really positive because we have been really focusing on returning back the hospitals to the communities and focusing on reinvesting. And when you can refocus the resources back to where the need is in those communities and eliminate any barriers or any when you come from a large system and you have multiple levels of approval to get things done, it can be a challenge and frustrating. And so with our organization being more efficient and nimble, we can make decisions very quickly at the local level and at the system level to support that process. From a culture perspective, also we had multiple meetings leading up to both the leadership and board and staff, and then of course we had celebration parties afterwards and handed out prizes, ate and celebrated, trying to bring those cultures back together. And it was really positive to see the feedback and support, and continue to focus on that, focusing on engaging the employees and the staff, the physicians, and helping us guide the hospitals.
President Norris, question of Mr. Gallagher.
I do. How do you hope to engage our community? We have a good hospital, we have some great staff, but we're having a hard time engaging our community and keeping them from running to Seattle and Bellevue. So how do you think you're going to be able to help us bring those patients here?
So one of the things I noticed in the data was that there are folks that are seeking care. And so it's when you look at access to care issues, sometimes it's a chicken and egg scenario. So if you don't have a provider in market, or you don't have the right provider or providing the right service, or one of those permutations, then folks will either leave town to receive care, or somebody else will come into town and provide that care. So from that perspective, I think looking at the community health needs assessment, and in that community health needs assessment, as you're aware, you get feedback from a lot of different community members or leaders or in that process to fulfill the 990 requirements as a 501c3 and ACA requirements. So that process is really important to make sure that you gather that information, and then you marry that with your medical staff, along with the data, like similar to what Jody shared earlier, to focus on that. People are busy these days. They're engaged. A lot of different activities in their communities. And sometimes it's hard to get them on the front end, but when they need care, having providers in market that can provide that care based on what their needs are and wants are key to engaging those folks.
I do a follow-up question, or do I have to wait again?
I think you should wait, President Norris, since you've given me the opportunity to be moderator. I'm going to be a little bit of a taskmaster because I want to make sure everybody gets their questions. But we'll come back to you, I assure you that. Vice President Young.
Okay, first question, is anyone looking at a copy of the PowerPoint? Okay.
That's kind of a preface to that question. I think it's more of a statement. Go ahead, Vice President Young.
I understand that you're serving a large thoughts about how that's how we're going to service the district, how we're going to concentrate on this community?
Well, I think key to that is hearing feedback. There's a want, desire, and there's a data shows that is warranted and needed in other communities such as Affiliation. Then we need to evaluate how we can do that and facilitate that. One of the challenges, the areas that to be careful of is providing something that the community may or may not want. So gathering that feedback is looking at the data and seeing what can be provided and supported. So should there be a need to want it, then I would think we would want to do so.
Thank you. Secretary Spikers.
Thank you. It is conceivable that you may incur $250 million worth of debt in the year 2020. Why keep expanding, especially in Western Washington?
Could you,
And this is off of the public records that I acquired via your acquisitions.
so I think you may be referencing the replacement facility for Astria Sunnyside Hospital?
Yes,
Okay.
as
So-
well as potentially
Potentially. Right. Here. So we're working through that process with, on doing that. It's a $120 million replacement facility. And again, as you all are well aware of the critical access hospital process, our market there is 76% governmental. So we facilitate being able to acquire that debt, provide those services, and move on to continue to grow those services as well. So from that perspective, it's not an issue, and foresee that to be a problem.
the expanding. Why keep expanding? I think that was my main question. Sorry,
What else?
clarifying the question.
Yeah, I think that's part of the compound question. You know, attorneys do that.
Yeah, I know. Is that 1 or 1.5?
Yeah. So I think it's the other part of his question. So go ahead.
It was, why keep expanding and acquiring more?
Well, we think we have we understand and have a unique business model that we think we can help facilitate and share. We really believe that you get better care at home. You don't have to worry about all the extra social aspects of making arrangements, leaving town, to provide care in a local community as best as you can. And we think we have a pretty good model to help facilitate that and do that for communities. And so as we continue to grow and able to share that and support that ability of the communities that we serve, we think that we would like to bring more folks into the community. Plus, Snoqualmie has a great reputation for their swing bed program. We'd like to take some of the expertise that they have developed there and use that in some of our other locations as well.
Commissioner Herron.
Okay. The slide presentation on the organizational chart is pretty simplified.
Yes, ma'am.
Could you elaborate more on how the structure or the organizational chart for Astria? I saw that you have Astria Health, and then you have the 3 hospitals. That's all you have. Can you elaborate on that? Do you have like a board member, board of directors above the CEO?
So we have a system level board at Astria Health. It's a 509 C3, 4, one of the
4 or 5?
4 or 5, whatever it takes, at the system level. And then in each of the hospitals, we have 501c3 with board members as well. So each of those are independent boards, and Astria Health maintains reserve powers. So at the local hospital level, you have quality medical staff, your typical roles and responsibilities at the local hospital level. And then at the system level, they have reserve powers for they approve the budget on an annual basis that's submitted. They have capital dollar allocation and approval for projects and those sort of things. But the hospitals at the local level really have the ability to provide that strategic direction for the hospitals. And then, for example, so that's the same at each of the Sunnyside, Toppenish, and Yakima hospitals. And then we have a home health entity under Sunnyside. We have a home health and hospice entity under the Yakima Astria Regional Medical Center location as well. We have a foundation that is for Astria Health Foundation as well. It continues to support the mission for the hospitals.
Thank you. Commissioner Baldwin.
Yes, I found it interesting that you stressed the importance of the community needs assessment, which is of course required under the Affordable Care Act, etc. I wonder, have you read our community needs assessment?
I have not recently.
It is very important. I suggest you read that. I have any questions about that.
All right, thank you, Commissioner Baldwin. We're back to you, CEO Parker.
Thank you. John, actually, this is related to community health needs assessment. You mentioned that you use that to look at what you're going to be doing in the future. It informs your strategic planning. Could you talk more about really what that process is? How do you take information from the needs assessment and work that through into your system?
Certainly. So the process that we've seen be successful is bringing folks in from the community together, inviting them into the process. After we go through kind of the data collection process, for example, similar to what Mr. Romer shared with you all earlier on the data demographics. We take that data and we marry it with feedback from the community in that community health needs assessment process in an initial meeting. We kind of gather what sort of things do you think the community needs, what areas are there problems, what area can the hospital or the health system focus on making an impact. So that's the first meeting. Then the second meeting, it's brought together or maybe the end of the first meeting, and those items are prioritized and meshed together. So you try and identify which items, number one, are within the scope of being provided by the hospital. There are some things that maybe we need more housing. That may or may not be within the hospital or the health system's control. It can help influence that, but it may not be something that we would need to actually allocate hospital resources to focus on. So we take that and kind of put it into buckets of what is within our realm, what is outside of our realm that we could perhaps influence. And so within our realm, then we take that and through that feedback process with the members that are participating in the community health needs assessment, we prioritize those in which we think is the greatest need for our community. That process, then we take that back. We focus on developing a plan of implementation and process for the community health needs to try and impact those areas. So then we bring that back a third time for our approval, and it goes to the board for approval, and then subsequent implementation by the executive team.
President Norris.
My question is also on the community needs assessment. We did a community assessment, had one done, and the same people attended it all the time. So we didn't get a good idea of what the need was. Now we got information elsewhere that was helpful for us that had our demographics and our population, all that kind of stuff in it. So how are you going to make sure that that you're getting the right information in the community needs assessment? Because the one that we have as a district that was done for us was not very good. It was very limited in who attended.
I think that could be a challenge in multiple communities. Trying to have folks provide that. So you really have to go out to relationships that board members and staff, a lot of the staff participate sometimes. They hear and they see they're providing care at the bedside. They know when there's an issue a lot of times that folks may not know about or hear about, so staff plays a big part of that as well. But that's probably one of the biggest challenges is engagement and doing the community health needs assessment. So I would say that personal relationship with members of the community, when we were doing our assessments in the past, I'd pick up the phone and call people that I deal with on different boards, or Rotary or your response or whatever, text folks, hey, come to the meeting, provide that feedback so that personal relationship, trying to get folks to the table, is what it has to come down to for business. Trying to facilitate bringing them into engagement is a challenge, but you have to make that effort. And I think the best way is through that personal engagement.
Thanks, John.
Vice President Young.
Your partner, next to deal with is an exercise.
Very good.
Secretary Spike.
Okay, well, you've added 76 new physicians. That's pretty amazing in a short period of time. And 16 to just the two recent acquisitions, right? So that's like in 45 days.
Well, we started a little early.
What's your strategy for attracting, areas that might be of need in this valley? Say a orthopedist or any other specialist. What's your strategy?
Well, I think, key is selection. There are a lot of folks that are out there looking for opportunities, and I've been in some relatively much more rural communities than this in the past. And the key is finding the right practitioner who's looking for that opportunity. There's something to say for being a larger fish in a smaller pond sometimes. Also, you have to make sure that you're recruiting the right practitioner. I remember doing a phone interview with a provider, and they asked how far away was the nearest Nordstrom's, and I told them that this probably wasn't a good location for them. And then moved on. So it's being honest, open and honest with that process. It's also, in smaller community hospitals, rural hospitals, you have an opportunity to have a broad scope in your practice versus if you're in an acute location, you're probably pigeonholed into a certain area where the group needed somebody to cover this. And so you may be trained on this, but you're going to work on this. So that opportunity may be attractive to some practitioners. The other one may be attractive to others, but you have to look for somebody who wants to have that broad practice. And then focusing on as well the model that we utilize, at least on a physician deployment perspective. We're seeing a lot of folks coming out of training who just want to focus on medicine. They don't want to mess with the business of medicine. And so our model is one that allows folks to really focus on the business of medicine, take care of patients, and let us worry about the back office and on the business side of it, so they can really focus on that interface with the patient and trying to provide care. So that's what we try to offer for them.
Chief Gallagher, I'm going to bring you some water. You have been talking for a long time. I don't know how you're able to do that.
I talk a lot.
Let me do that for you.
Thanks.
You are welcome. So just take a couple of those sips. Commissioner Heron.
One of the challenges that our hospital has of migration, we are a young community, but we do have mixed population. And there's many healthcare needs. How can Astria help our hospital bring our residents into our hospital rather than going to Overlake Hospital or Swedish?
Sure. The key to addressing out migration, it's pretty proven in the industry, is you have to have providers available in the market so that patients can seek care in your local market. Most folks would rather go to a local provider, all things considered equal, versus driving and getting in the car or going someplace else. In the local communities, in the community health setting, typically you can, without a problem, provide care for 70% of your market. There's going to be that quaternary care, which is the top, 5-10%, some tertiary stuff that you can't take care of in a setting. But there's a large population that you can take care of locally if you can provide that care, if you have those providers and folks have good experience.
Mr. Paul, I want to discuss Sunnyside, which is your flagship hospital, as I understand it. Is that correct?
No, sir, the Astria Regional Medical Center is the 214-bed tertiary facility with open heart, neurosurgery. all of that.
That's located in Yakima, is that
Yes, sir, that's correct.
Okay, well, then you've got Sunnyside, which is farther from Yakima than we are from Seattle. You know, so you have an advantage also of being the only provider in that area if you take all of the facilities together, except for one. And you haven't mentioned that, and that is the former Yakima Memorial Hospital, which is now Virginia Mason Memorial. And so one of the things I'd like to know is what is your relationship with them?
With Memorial?
With Virginia Mason Memorial in Yakima, which is the largest hospital in the area, as I understand, 350 beds.
We have a cordial relationship. We work together on different things. We have medical staff that flow back and forth between our hospitals, Astria Regional and Memorial. So I think we work together to try and take care of the community. We're also in different plans together and continue to support each other to really make a difference in our community. So, I mean, choice is important. And incredible choice is important. So that's one thing that we really focus on is I think that patients get better care when they have a choice of places to do it. Because then we're all focusing on trying to take better care of the patient.
Well, I'll come back to you, Commissioner Barlow. CEO Parker.
Thank you. John, you mentioned this in your slide. Your slides answered a lot of questions, but how is Astria preparing for the shift away from fee-for-service payments for healthcare services to value-based payments? And most particularly, I'm curious about how your approach to population health payments.
Certainly. Well, I think I mentioned that Magnolia Evergreen ACO is a Medicare Shared Savings Program. So accountable care organizations, as we all know, medical staff, CMS is requiring practitioners to participate and will be impacted by MIPS. Therefore, alternative payment models, including value-based purchasing and ACOs, are really important as we continue to move forward. Magnolia Evergreen is a ACO that we're an owner of. Again, we've seen really positive aspects through that process and also through earlier grants that we utilized with HRSA. We focused on having care coordination. So we have care coordination in our clinics that focus on chronic care management, specifically diabetes and congestive heart failure, those sort of things. So we're actually focusing on getting folks in, making sure they're weighing themselves from a congestive heart failure perspective, or doing their sugars on diabetes and those aspects. So focusing on those chronic care things, trying to intervene early so you can bend that cost curve. Because we all know if somebody has an event, ends up in the ER, and ends up in an admission, the cost for that episode is going to be much higher. If we can intervene early through that care coordination process, get them into the office or get them into a specialist sooner in that cycle as that continues to deteriorate, then we can do that at a lower cost setting than having it without that process.
And did you say it's a HRSA grant?
Yes.
President Norris.
You started your presentation saying that regional health had been around since 1947,
Yes, ma'am.
but all the information you gave us was much more recent.
Yes, ma'am.
Can you fill in a little bit of that gap of who they were in 1947 and a little bit of how they got to where they are today?
I can try. So,
I'll be
have to
patient.
remember. Okay, so.
But there's a lot of years missing there.
Sure. So, and I referenced 1947 as that was the original date that Prior Snoqualmie Community Hospital was created. So it started post World War II. Hope Grant started as a 9,000 square foot facility. Added on, I think, another 15 or 20,000 square feet as it continued to grow. It was an MD-only facility at that time, and there were DO physicians in the market. And they actually started a separate hospital around the 60s, I want to think. So we had two hospitals in Sunnyside for about, like I said, about 20 years with multiple expansions on both sides for both hospitals. And then sometime around 1982, anybody know what happened? This thing called DRGs. Who knows? Okay. Poof, DRGs, right? And they realized that they couldn't do it by themselves, so they came together and merged, moved to the better physical plant, I guess, at the time, which was the current location, and continued to expand over those years. 97 was a new ER, I think, and all private, and added an expansion on the beds. And then from 2012 to 2016 or 17, represented there with the additional services that we've offered at that location. So I'm just trying to kind of squeeze that there for you. Hopefully that gave you a little bit of a picture.
I think it's up to start with.
Okay, very good.
Oh, you said DRG, what does that stand for?
Diagnosis related treatment. That's when we went from
I didn't.
Nurse, too.
They didn't tell us about that modern day. In the 70s, they were talking about DRGs.
You never filled out this form.
Vice President, yeah.
Happy with,
And you'll pass, I'll come back to you in case you have another thought later.
I'm having fun.
Secretary Spike.
Every one of us on the board is very passionate in trying to make sure we get the best healthcare in this valley. We try very hard, we're very passionate, not one of us is not. And yet, no matter what we've done, we haven't quite reached all of our districts. For instance, I think Commissioner Jones said, our nation doesn't quite get the services because they're so far strategic, they're far away from the central hospital area. And what is Astria prepared to do, perhaps, to help bridge that type of gap to the rest of the taxpayers that feel that they could be cheated in not having services?
Sure. Again, if I go back to the population part, I'm looking at the population of these different communities. There are different ways that you can facilitate getting care to the community. You could drop a point for people and have free access. You look for opportunities to utilize technology or visiting practitioners as well to an existing facility in that location. You could think space on a daily rate from a building there and provide folks on a daily basis. But there's different aspects. We mentioned earlier the student health center, and through a technology process, putting iPads in the school nurses, so that folks, if kids come in and they're ill, they can call up through telehealth, talk to the pediatrician at their PM, provide access to care that way. So technology is a way, bricks and mortar, or innovative solutions, partnering with different providers that may already be in market, dentists, those sort of things. There are different ways that you can create access points.
Commissioner Herron.
What is Astria Health's total budget now that you have acquired those hospitals? And what is the budget for each of those hospitals?
Okay, so it's 1.13 billion
For all three?
for all three. And I think there's 700 million at Astria Regional and 300 million at Sunnyside, and about whatever's left, 100, I guess, at the top.
Commissioner Paul.
You mentioned Sunnyside, and you showed us PowerPoint on the services. And right away, I'm very thankful if you're going to give us copies of the PowerPoint, because that went very fast. And you spoke very fast, so I couldn't really read all of the PowerPoint.
I was worried I had 88 slides that I wouldn't get through.
How many slides do you have?
We have 87, I think.
I was going to be modest and say 75. First, I was going to say 100. I said, no, 75. So, in between, yeah. That's a pretty tough assignment. But at any rate, it was rather amazing, all the services that are being provided by Sunnyside. But we have to remember that Sunnyside is not just a 25-bed critical access hospital like us, but because of the exceptions allowed by CMS and so forth, you have 20 more beds, 10 of them for acute rehab and 10 for mental health. So really, Sunnyside has 45 beds. We have only 25 beds. Isn't that correct?
No, actually, we have licensed 38 beds, but we operate 25. Okay. We have approved certificates of need to add 10 psych and 10 acute rehab. So we have not actually added those to the facility as of yet.
Would that be added to the 38?
Yes, sir.
So you'd have 38 plus 10 plus 10?
Correct.
48, 58.
Correct.
Well, see, we have less than half that here. It provides quite a contrast. But I just wanted to clarify that so that when our services are much more modest, we keep that in perspective.
Sure. I mean, just from a perspective of 20, I think we mentioned just prior documents that are out there. 26% of our revenue is inpatient. So 75% of our revenue is outpatient services, which is where you could really focus on growing some business as well. At this location, even though you're 28 beds, that doesn't necessarily have to hinder the delivery of care. As we all know, healthcare is shifting from an inpatient focus pre-DRG, right there, pre-DRG inpatient focus, where folks used to be admitted, so you go out of town and everyone got a workup and then you came back. So we know that, and it's now moving to outpatient focus, where you have folks doing, MAEs and ambulatory surgery center that used to be admitted. So we have seen that evolution and that focus to move to the outpatient setting, to where it's not as inpatient intensive. So I think that Snoqualmie is actually positioned in a really positive way. So you can focus on providing inpatient care where folks need inpatient care, but also focus on the outpatient aspect to deliver that care in the most efficient and cost-effective manner for the facility.
All right. CEO Parker.
Well, you're sitting next to our CFO,
And we've been ignoring him all night long.
Right. We always do. In our work study sessions, all of our staff get to participate. I just want to know if Steve, you've got any burning questions?
No, they've all been answered.
Okay.
Are there other staff or your management team present?
Our other member of our executive team tonight is actually at a meeting. It's actually an annual meeting of all the users of our electronic medical records. So she's getting the latest. We do have a couple of our directors here with us tonight, and
Can we inquire if the directors have any questions?
I would love to hear if any of our directors or other staff. I shouldn't limit it just to the directors, but we do have staff here tonight. If they had any questions.
So,
I've never heard you excited.
well, I've never been put in this position before.
Let me introduce, this is Ron Bennett. Ron is Director of Pharmacy and Medical Imaging.
Thank you. So, just from a staff perspective, right? So real talk, when staff hear that we're looking at affiliation, of course they're concerned about what does that look like and feel like, and this big, Astria come in and bulldoze right away. I'm sure you do purposeful things to help that transition. Can you explain that a little bit, what that looks like?
Certainly. So, for example, in our recent acquisitions, putting out early communication through in conjunction with the executives at the hospitals that we're acquiring about benefits, longevity, how that process would work in transitioning from pre-acquisition to post-acquisition, health benefits, insurance, all those kind of things. So getting that information out early to be able to limit that impact. We also provided community form or employee forums where we would actually talk about where we are in that process and be able to answer any questions or gather questions that were forthcoming, and then be able to respond to that. Put out frequently asked questions to the staff. As we move through that, as we hear feedback from different rounding events that the leadership did as well. So, information is key, communication is key. Where there's lack of information, that's where we get things floating around an organization that aren't true. So we try and limit those opportunities and try and give that immediate feedback as well. Thank you. You're welcome.
There's another individual who is the clerk of the board and the executive assistant, and I always ask her when I do presentations if she has any questions. And so, Valerie, I'll ask you again. Any questions, Mr. Gallagher?
I don't.
All right. Thank you. Back to you, CEO Parker.
Thank you. John, you, in Don's presentation as well, talked about the outflowing of support from the communities in anticipation of the transaction. Could you talk for just a minute about any critics that were worried about that transaction and how you responded to that? And, what were some of the arguments that people were making that you responded to?
There were a lot of details because some of the criticisms were just not accurate, so we had to do a lot of fact correcting. Even our direct competitors didn't challenge us. They just brought questions up on analysis where their analysis, even their math calculations on some of the things weren't even right. So we weren't quite sure what they were looking at, but it wasn't what we should put together. From that perspective, there were actually folks in market that came in and essentially didn't want us to start services or recruit additional providers. The response that I gave at the public hearing, which is in the documents there, is that we're hearing feedback from providers and the community that they can't access care, and have asked us to do so to recruit additional providers into the market to reduce wait times and improve access to care. And that's what we're here for. It's not a personal issue, it's an issue of trying to meet. So those are probably two of the areas where we were able to address.
President Norris.
I think I'm satisfied with what I've heard so far. I can't, the other questions I have are probably questions that we need to talk about as an entity versus what you presented. I think you did very thorough, gave us more information than I think some of us thought we would get, which was very good. And I think I'm going to pass right now. I appreciate your time.
Secretary Spiker.
We've got, I think, one more impressive question. How will you, we're going to be, if you were looking perhaps as a lease, having to pay the annual bond, operating or the revenue bonds of $3 to $4 million a year, how are you going to absorb that? Until all of the parts of your system get up and running. Right? So you're going to be $3 to $4 million a year, to lean the lease, right? So,
and that's currently, I think that I'd really like to keep kind of that transactional type of things, focus and diligence, because we haven't really had an opportunity to look in too much detail about the lease transaction, not perspective. So I'm not exactly sure how to answer that, but I don't have all the
Okay. Earlier I asked about the budget.
Okay, yes, ma'am.
And it appears that Astria is financially stable or sound. That's what it looks like to me. And where do you get your revenues? Where's the money coming from? I guess my question to purchase, or not purchase, to affiliate with Snoqualmie Hospital.
So again, it's a little transactional in nature, but we have capital, lines of credit, all those different aspects that we can access for us to accomplish like that.
Does that answer your question?
Yes, yes.
Very good. Mr. Paul?
How long did it take for you to drive to Yakima or Sunnyside, or wherever you came from?
I think we make one. We stopped and make 2 stops. I think it was 2 hours and 20 minutes.
I guess the thing is that you show us a lot of those things going on over in Yakima. Are you basing any expectation on our people driving over to your service area to get services? And do you really think that any of our people would do that?
So as you may recall earlier on in the presentation, and a couple times throughout, our focus is different than maybe other folks that you meet. Our focus is that we believe that you should build services in a community as best you can to take care of the community. Folks are going to leave for primary, tertiary, those sort of services. And folks may go down the street, they may go across the country, they may come to Yakima, who knows. But our focus and what we think we're good at is supporting local facilities to grow services in the communities to meet the community.
Okay. Well, I'll come back. CEO Park.
Oh, we're getting down into it. This is a 2-parter. Sorry. You have a Cerner at all of your sites right now?
We have Meditech, MedHost, Centricity.
Okay, so then that's great. Can you talk about your plan for integrating electronic medical records?
Sure. Right now, we're going through a build process with Cerner. We're building out both ambulatory and inpatient, bringing folks together in a year-long build process and implementation process. We'll go live in July at Sunside Hospital, and August and September, I think I'm correct, at September. We'll be doing about both at the same time. In August and September, the other 2.
So by this time next year, we'll be standardized on Cerner.
Thank you. President Norris, pass.
I am.
Vice President Young. Secretary Swack.
Just one last quick question, and this is more of a general one, so you can make answers. I apologize.
The answer is A.
Seeing what I can get. So what is the vision, not Fred, the vision for making this hospital, this district hospital? What's your vision? What do you think?
I mean, I think it's back to basics. It's really providing care or having access points and providers, primary care, subspecialists in your community to take care of your community. So I think that is the key to making the hospital profitable, offering additional service lines, looking at what the market's accessing, what can we do, what can we start here to provide care locally, be that OB, surgery, greater emphasis on different outpatient services, and whatever it may be. Looking at the data and then building a plan to access those points, because hospitals are like, it's like industry, right? It's going to cost you X amount of dollars to keep the lights on, to staff the building. If you can move more patients through from, let's say, an outpatient basis, that's going to be incremental revenue at a lower overall cost per encounter and per patient. So if you have those access points in your system through primary care or specialists that choose to use your facility, they can lower the overall cost of care for each encounter. And that should help distribute your overhead and provide for more margin. Thank you.
Commissioner Herring.
Most hospitals and health systems are JACOB certified. Our hospital is certified by DOH. And so, as I think Astria Health is not JACOB, so when you showed us your slide, you showed several different accreditations. Is there a future accreditation for Astria Health to look into becoming a JACO certified facility?
Certainly. So, Astria Regional Medical Center is JACO certified. Their lab is actually CAP certified. So you have to do JACO or CAP, one or the other. And Topnish is also JACO certified. All of our multiple imaging modalities throughout the system, be it at Sunnyside, Topnish, or Yakima, are ACR certified, which is the American College of Radiology certification as well. Sunnyside is DOH as well, and we're working through that process to go for accreditation as well. So I would see that Snoqualmie could move in that direction as well, for sure.
Mr. Pollard.
In the presentation, either you or other people identified a dominant provider in our area, but didn't name that provider. I wonder if you could name that provider, and if not, I'll deal with it hypothetically.
I think I'd like to hear if you know who the dominant provider is.
Commissioner Pollard, hypothetically, who would this dominant provider be?
Well, hypothetically, the dominant provider is probably Overlake, but
Actually, it's not.
okay, if not, then it's Swedish. Yes, it is. And I guess that leads to my question, which is, we have this situation where we're 9 miles from a 175 bed approved hospital, 80 bed certified, maybe 60 or so occupied, many vacant beds, but 175 bed general hospital, 9 miles away, or 10 minutes by freeway. So when you talk about things like setting up a surgical center and so forth, it seems rather unrealistic that people could just go 10 minutes farther and then come to this 175 bed hospital. I didn't see Swedish listed on your various branding options and so forth, or providers around the area. What would you propose to do to meet that kind of competition? But that's not the only competition. For example, Evergreen, which is close to Carnation, only 3 miles different, getting to Evergreen from Carnation when you come here, is the #1 stroke center in the state and one of the top 5 in the nation. That's pretty tough competition for some things. I guess what I'm saying is, you don't, in the Yakima Valley, you don't have the kind of competition we face with the greater Seattle, what I call the greater Seattle health resource area. Tremendous number of hospitals and resources within 45-minute drive. So what would you propose to do to counter that kind, or to compete with and make it constructive, that kind of competition?
You mean these guys right here?
It's Swedish.
Right.
Oh, Swedish? Oh, Swedish. Okay, well, I guess the thing is that Swedish is a clause.
Oh.
Is what they have various Swedish facilities.
Okay, so I think the key is you know, I've been in very competitive markets throughout my career, and really what it comes down to is taking care of patients.
Is what?
Taking care of patients.
Well, obviously.
Obviously, that's why we're all here, right? And if you can get care from your neighborhood or provider who's down the street, so you can run by and get care at a convenient process, so that you don't have to drive 30 or 45 minutes, fight the exit at 18 in the freeway, which is, you know, lots and lots of cars sometimes. When you're waiting in line, you just want to make a left turn, just want to make a right turn to get home. If you can get to your local community hospital for the majority of care that you're going to need for you and your family, why fight the traffic? You know, so I think that when you look at that, it is a choice, and it allows for that choice. And there are going to be things that you need to go to the guys downtown for. But there's a lot of things that you don't need to go to the guys downtown for. There's a lot of things in healthcare world that if you call from a local community and say, I have this situation, they're like, you can take care of that, keep it here, send me your fancy stuff. I mean, that's really what a lot of the health systems from the tertiary world want to hear.
CEO Parker.
Good, thank you.
And President? Vice President? Secretary?
I'm good. I like the last response.
Mr. Heron?
I just heard of, I think Miss, the consultant. You had mentioned about SVH market share is exceptionally low, 1 to 2%. How would you raise that level up to meet that? How could you help us with that?
Go ahead, Joe.
So I want to start with a little story.
Okay.
So I had a meeting and I stayed overnight in Ellensburg last night. I live in Seattle. I had to be to a meeting at Broadway at 8:30 this morning. I left Ellensburg at 6 a.m. It was foggy, 38 degrees. I made it to North Bend in an hour. So I thought, I'm gonna have a lot of time. I'm gonna get to stop at Starbucks. I'm gonna have some breakfast before I go to my meeting. From North Bend to Seattle was an hour and 15 minutes. So to think that you're 10 minutes away from another resource or another is at 7 o'clock in the morning. I didn't make my meeting on time in downtown Seattle, so I didn't have coffee. The day went downhill from there, but that's okay. But what John is saying is so very true. I don't know that we want to measure you by inpatient market share, but there are. I look at your market and there are incredible opportunities. Choice is important, but people want to stay locally. And so if you have those access points that are convenient, open at the right times of day, family-friendly, senior-friendly. And when I got downtown, it took me 15 minutes to find a parking spot. Look at your parking options. So you really have, I think you're underestimating what you have to offer this community. I think it's a sustained marketing program after you have the programming in place to support them. And there is no doubt in my mind that you can move that needle significantly. Really a lot of opportunity.
Answer your question, Commissioner. Thank you. Commissioner Paul?
Yes, in your certificate of need, you appear like it went sailing through, but the Yakima newspaper said certificate of need granted but. And so apparently the journalists there tried to find out what the but meant, what's the situation, what are the conditions. And I believe she was told that we're not going to respond right now, we're going to respond to DOH, and when we do, we'll inform you. And so the question is, what were the conditions for you to receive your certificate of need, and why couldn't those have been made public immediately, since there was a public process?
The conditions were immaterial. They were things like, one was keep the hospital open, I can buy it for a while, so they didn't want me to spend money and then close it, which I was okay with. Because that's not why we're taking care of communities. We're there to build communities and provide care to the communities we serve. So there were conditions that are typical that you see if you've had a recent certificate of need process, approval process. They typically put things on there that are called conditions, such as we'll have a policy and show it to us on, maybe it was a charity. We'll have a policy and show it on perhaps, I can't remember, there were 10 minor things that we took care of, I think the day that we got the CN, right? And then we closed the next day, meeting those conditions. So we had, from when we got the information, we did all of the conditions, turned it into DOH, and we closed the transaction and acquired the hospitals the next day. So we were walking through that process.
And you know what, we really liked the elements.
I'm sorry.
We really liked the element of surprise, but
tomorrow we're gonna be closing this deal, but
I guess the second part of my question was, if they were so meaningless, why didn't you release them to the newspaper right away?
Let's just do the two. We did.
And coming back around, anyone else? I think I'm back up to you, Commissioner Herron.
that was my final question,
Well,
Final
if
answer.
something else comes up, obviously, we can take up more questions, but Commissioner Paul.
In one of your models, I guess this was the merger model, you said there'd be a new board created. And it's not clear, would that be elected by the people, or would that be appointed by your organization, or what?
It's a little bit detailed and transactional, so the elected commissioners would still have their role as the district, and then the board as the 501c3 would not be the commissioner type individual. Elected positions, that would be stay at the commissioner level, and the local board would be appointed.
So,
For some
clarification, you said that the elected board would have its role, or they'd have their role, I think that's what you said. The role of the board is not only to pay the bills and sign the checks, it is to set policy for the district. That role would be weakened or eradicated under at least the merger model, and it would be limited under any other model that you could propose. Isn't that true?
I can't comment on that because it's probably detail oriented in a transaction.
Other questions, Commissioner Paul?
Could you comment on the lawsuit that you were involved with the Yakima Valley Community Foundation about a year or two ago? And I noticed that they made a comment on your certificate of need application that raised concerns, as did Yakima, Virginia Mason.
Call for the question at this time. I don't think
Well,
this is a.
I think it's kind of a point of order. So Commissioner Pollard, if I might, we're here to get questions and answers on their response to the proposal. So if we can more narrowly question the response and the proposal they put together, as well as the slides and the presentation. Otherwise, we can probably get some additional information.
Okay, then I'll ask a question directly involved with their proposal. And that is, the statement was made in your proposal that the current executive staff will continue, and you only devoted about 2 lines to this, not only during a transition period, but it appeared that they would continue indefinitely, subject to performance, of course. Is that your intention?
We like what we've seen from the team so far. We would expect to bring the team over.
Commissioner Paul?
What is your organization, if you don't think that this goes beyond the scope, the cost of living increase that you're going to be proposing to your people, and how does that affect your financial status?
It's not something really that we're here to discuss at this time.
That might be rather proprietary for them to discuss union and COLA increases. So,
Okay, I'll just summarize with one more approach and question. And that is that when the board got together at the strategic planning session, they focused on 2 things. One was financial viability, and 2 was branding. And I guess I'm concerned. I know the branding is very creative and it has great meaning in Italian and Greek mythology. But I think our people in the valley would see that as meaningless. And I contrast that to, let's say, branding where Overlake would put their name on our building, or Evergreen, or University of Washington, and so forth. Your brand may be very valuable someday, but it's only a couple of weeks old. I don't think that our people.
Point of
Well,
order.
let me ask the question. You're right, but let me ask you, how
Secretary
would
Snyder,
you,
here comes the question.
how
Go
would,
ahead.
how would you
Commissioner Paul.
propose,
Thank you.
how would you propose to get over or perhaps educate people on the value of Affria as opposed to what could have been another brand? Because a brand has to be instantly recognized.
I think there's a question there, Commissioner Paul. Thank you. Go ahead, Mr. Gallagher.
All right, thank you. We would, again, do a marketing campaign similar to what we shared earlier in the presentation to get the word out and educate the community based on our value proposition.
Any last question?
Yes, I'd like to know whether your organization would be subject to the Public Records Act of the state. It's my understanding. Could you just respond to that? If a citizen or official or even a commissioner were to make a request for information or records under the state's Public Records Act, would you be obliged to respond?
We're not, so
I have more questions, but obviously, since
Well, I think we're running out of time. I think that staff here, CEO Parker, would work with Mr. Gallagher to get some additional questions answered. Does that work for you?
Yes, and our consultants who have been engaged in that since our work study session where we did come up with a list of questions, and Astria has provided the responses to those, so they'll be talking about that tomorrow.
So with that, Commissioner Pollard, we don't want your questions to go unanswered. I think the forum for this evening has probably come to a conclusion, but if you can prepare those questions and get them to CEO Parker,
If we were to pose other questions in writing, would you respond quickly as possible?
we are very interested.
Pardon, I can't hear you.
We are interested in moving forward with the process.
And so the answer is yes, or that seems to be a non-sequitur.
Yes, we'd be happy to see if we can answer any questions.
So with that, Madam President, I think I'll relinquish my duties and opportunities as your moderator and turn the meeting back over to you.
Thank you.
Yeah.
Next on our agenda is public comment, so if there's any public comment. Thank you, yeah, we did one. Okay, but I want to, are you ready to, you have a public comment though, right? Not a question. This is for public comment to the board. Correct?
Okay.
Yes, all right.
My question to the board is, what is the impact?
Just a second, sir, if you could just go over to the podium and identify yourself.
Yeah.
And
Just a clarification, this is a public comment versus a Q&A.
Right. Larry Fisher, Snoqualmie Valley Rotary Club. And my comment is, I would very much like to know what the impact to the hospital district taxpayers would be under this proposal.
Madam President, you can inquire if there's any more
Is there any
comment.
other public comment?
Just a brief comment about branding and social media. Branding is the promise that an organization has to those constituents, their customers, or in this case it would be the patients and the families of the local community. I would encourage you to check out the Facebook and Twitter and the other social media accounts that Astria has. Take a look at the energy that's behind it, take a look at the connectedness, take a look at the two-way communication. It's almost like eye contact, and make a determination yourself. Now, it doesn't, it takes 6 months to get real traction from zero. So I wouldn't expect anyone to be able to come in and have instant recognition. If you have an Overlake or a Swedish come in for branding, then they're not going to be able to present what is special about this community, about this district, about this hospital to the larger community. They can only provide their own promise. So I would encourage you to take the long view, to work for 3 to 6 months, to put some energy behind it, to open up, tell the stories, and to create community locally. And that's kind of what I meant by fire in the belly, because you can tell by one's social media footprint, the proofs, it's called social media proof. You can tell an organization by that, and from that, a trust is established. And trust is not done in internet time, it's done in real time. So I would really encourage you to take another look at social media and the way that organizations build relationships with their local community. I know this is a big concern of yours. Thanks.
Thank you. Is there any other public comment?
May I make another?
Seeing as you didn't do the full time, sure.
I would like to say congratulations to the staff here. My wife and I come here for whatever we can use out of the community, but you're a well-kept secret. Most of the time when we tell people we came up here for this, that, or something else, they didn't know you did that. So when I hear the comments like expand your outpatient services and make it broader, a lot broader, because some of the people that we come here to see are only here once a week or every other week or whatever. So you gotta kind of really plan to use the place. So if you could go to say what do the people need? Go to the 80-20 rule. What do people need 80% of the time? What's their 80% of their outpatient medical needs? And provide that. You know, it's kind of like looking at the dirty dozen on the organic food list. You know, figure out how to take care of it, and you'll get a lot more businesses because everything you said about, hey, drive up here, it's nice parking, and the whole thing. You know, that's my advertisement. And I don't know him.
Nor do I.
I want to thank CEO John Gallagher for coming and bringing his team. And I didn't say your name right.
Yes, you did.
Okay, Gallagher. His team to come and speak to us. He gave us a lot of good information. We appreciate your time. And I'd like to thank the board for being so organized and asking good questions, because each question helped all of us understand something that we haven't necessarily thought about. Our next special meeting will be Thursday, October 26th. That's tomorrow at noon at Snoqualmie Valley Hospital. Our regular business meeting is Thursday, November 2nd, 2017, 6:30 here. Annual budget public meeting will be Thursday, November 9th at 6:00 p.m. here. And I would encourage those that live here to get the word out, because we need input from the community, and we want to give the community an opportunity to know what's going on. And that would be it. Do I have a motion to adjourn?
I make a motion. I make a motion to adjourn.
Second.
All this, any discussions?
Yes, one discussion.
Oh, yes.
You're gonna announce.
There are refreshments in the back. Let's have some refreshments. All those we had a first and a second, yes?
Yeah, I did.
All those in favor say aye.
Aye.
All opposed?
What are you doing?